Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville and I will be serving as your program facilitator and will present your questions to our panel of experts. Our experts tonight will talk about cancer signs and symptoms, which recommended screenings you may be due for, and ways to prioritize your health in your everyday life. Thank you for submitting your questions in advance of tonight, and the questions that you will hear me asking the panelists are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during tonight's virtual event. And due to hospital university guidelines and privacy, we are unable to comment on specific cases. Likewise, if you are experiencing any symptoms that may require immediate medical attention, please consult a medical professional. Well, without further ado, I want to go ahead and introduce our experts for the evening, starting with Dr. Casey Deegan, medical oncologist, and Dr. Robin Wilson-Smith, DO, Medical Director, Gynecologic Oncology Services. And I'll let you both go ahead and introduce yourselves before we get started. So Dr. Deegan, I will go ahead and start with you. Welcome.
Hi, everyone. Thanks for having me. My name is Casey Deegan. I'm a hematologist and medical oncologist with Jefferson Health Northeast. I practice primarily at Torresdale Hospital, where I see a variety of conditions, but with a specialization in breast cancer and hematologic malignancies.
Thank you so much. And Dr. Wilson-Smith, welcome. We're excited to have you.
Thank you. Good evening. I'm glad to be here as well. As mentioned, I'm Dr. Robin Wilson-Smith. I'm a GYN oncologist that specializes in the focus of caring for women with cancers that originate from the GYN tract. One of my primary interests is robotic surgery, and beyond treatment, my passion lies with proactive measures, specifically cancer prevention through lifestyle changes. And I'm looking forward to sharing my insights from my experiences along with Dr. Deegan. And I practice in our Sewell, Jefferson, Washington Township location.
Hey, great. Well, excited to dive into our conversation. I know that we have a lot to tackle, so let's go ahead and get into it. So Dr. Deegan, I will start with you first for our first question of the night. What are the best tests for detection for cancer?
So the best way to detect cancer is to really know your body, and of course to stay up to date with your screening. So that includes tests like mammogram, colonoscopy, pap smear, and CAT scan of the chest for lung cancer screening if you are a smoker or have a history of smoking. And these days, there are a lot of things out there that are advertised as tools for early detection, like blood tests or whole body scans. And we really kind of are skeptical of those. They're not supported or validated by many medical associations. And that's because there's really not enough evidence to recommend these kind of things for patients that have no symptoms or really no strong family history. So they can be very expensive. They're often not reimbursed by insurance. And they can provoke a lot of anxiety for patients and their families. So I think the best thing is to know your body and stay up to date.
Okay. Well, thank you. And a follow-up question here. Are there different tests for different stages of life?
There are, yeah. So pap smears are recommended starting at age 21 to screen for cervical cancer. We recommend mammograms at age 40 for breast cancer screening. Colonoscopy has an interesting history. We used to suggest that people get it at age 50, but we've now actually moved that up to age 45. And that's because we've been seeing a rising number of young patients with colon cancer. And then lung cancer screening is recommended for those who are 50 and older who have smoked a certain amount of cigarettes in their lifetime.
Okay, well, thank you. Appreciate you walking us through that. All right, Dr. Wilson-Smith, we will turn to you for our next question. After a hysterectomy, what are the chances to have ovarian or cervical cancer?
This is a very good question and actually a complicated answer. It really depends on the type of hysterectomy that you have. A lot of people, when they say I have a complete hysterectomy, most of the times they're talking about removal of the uterus, the cervix, the fallopian tubes, and the ovaries. But for us as surgeons and as physicians, a complete hysterectomy to us is just removal of the uterus and the cervix. It does not include the ovaries and the fallopian tubes. And for us, when we're talking about a complete hysterectomy, of course, we make it complicated. We say hysterectomy, bilateral salpingo-oophorectomy. So when you're talking to your provider, you have to be specific, because for us, a complete hysterectomy means something completely different. So that being said, when asking what your risks are about after having a hysterectomy, it also depends on the type of hysterectomies. There is supracervical hysterectomy, there's modified radical, there's radical hysterectomy, and then, as I mentioned, there's removal of the ovaries and the fallopian tubes. So I like to think of the uterus like a light bulb. The white part of the light bulb is the uterus. The silver part of the light bulb is the cervix. If you only take the white part of the light bulb and you leave the silver part, which is the cervix, and that's the supracervical hysterectomy. Those patients have the same risk as if they had never had a hysterectomy, if the cervix is left in place for cervical cancer. And the same thing goes for ovaries. If your ovaries are there in place, then you have the same risk as the general population, unless you have some type of genetic abnormality. So it really depends on, what we're talking about. And then even for women who are at high risk, let's say they have a BRCA mutation, even though we take out the ovaries and the fallopian tubes, they still carry a risk of what we call primary peritoneal cancer. It's very, 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 very low risk once the ovaries and tubes are removed, but the risk is still there, and it behaves very much like ovarian cancer. And the peritoneum is the lining that's inside of our abdomen. And then patients who have endometriosis, they also carry just a slightly increased risk of developing certain types of ovarian cancers in those patients as well. And it's just a slight increased risk. So a hysterectomy that removes the cervix completely will virtually eliminate the risk of cervical cancer. If the ovaries are left in place for the general population, the risk is relatively low, about 1 in 70. And this must be balanced, though, when you're taking out the ovaries, with the risk of cardiovascular disease, osteoporosis, menopause, sexual health, mental health, dementia. However, women with certain genetic mutations, that risk is then justified. So again, this is a very complicated question and answer, and warrants discussion with your healthcare provider based on your specific situation.
Yes, absolutely. Some important information there. And as you said, talking further with your healthcare provider. So thank you. Okay. For our next question here, we'll talk a little bit about breast cancer. Dr. Deegan, how do you detect the first signs of breast cancer? And are there any tests patients can do at home?
Sure. So sometimes breast cancer presents with a lump in the breast that can be felt, or a lump in the armpit. But actually, the majority of patients are diagnosed with breast cancer by mammogram. And mammogram is basically just an X-ray that allows us to tell if there's any abnormal tissue in the breast. And so typically a lump has to be about the size of a centimeter to be felt, and 1 centimeter is the size of a pea. So very, very small. But the amazing thing about mammogram is that it allows us to detect cancers earlier. They're smaller. They tend to require less treatment. And in terms of things that women can do at home, so I do recommend self-exams. I think, again, knowing your body is very important, and knowing what your body is like and what is your normal. And so I recommend that women do this 3 to 5 days after their period, when the breasts are less likely to be tender, and really important to just do it at the same time every month, and just to keep up with it so you can identify any changes.
Okay. Yeah, that's good to know about doing it at the same time every month. I wouldn't have thought about that. So thank you. Okay. And I guess a follow-up there too, are there any screenings that women in particular should be doing?
Yeah, for sure. As I mentioned, mammograms are a vital part of early screening and early detection. So we recommend that all women over the age of 40 get a mammogram. There are some women who should get screened earlier based on a family history. You could talk to your doctor about whether you qualify for that. But the best time is now. Some women who are still menstruating do find, again, that the breasts are tender sort of in the week before the period. So I usually recommend the week after the period, just to reduce the risk of discomfort. It can be a slightly uncomfortable test, but I think the benefits far, far outweigh the cons.
Okay, thank you. All right, Dr. Wilson-Smith, turning to you now, how often should women 70 years and older get gynecologic screenings?
Well, it really depends on which guideline you're looking at. We have so many guidelines. We have the American Cancer Society, ACOG, ACOG, SGO, ASCCP. There's so many guidelines that tell us, what type of screening we should be doing and how often. And unfortunately, they can't always all agree. So it really depends on which guideline your provider is following. It also depends on a woman's individual health history and her risk factors. Screenings that I think of at a GYN exam, as Dr. Deegan mentioned, pap smears, starting at the age of 21, although some guidelines are now recommending age 25 starting, and stopping at the age of 65, as long as you have had regular screening and your pap smears have been normal for several years, and stopping after a benign hysterectomy. Pap smear. So pap smear is one of the screening tests. Pelvic exam is another screening test over 70 that I think should still be done. This is very controversial, and the guidelines vary with regards to this. Some say no and only if you have symptoms, but I personally perform them. I personally think they're important, as there are areas that women are not seeing, their vulva, their vaginal area, and once a year touching base with a provider to examine you, I think is really important. And then mammogram, as Dr. Deegan has covered, which, that varies based on organization as well, but as she mentioned, starting at age 40. And for us, we usually keep doing it as long as, it seems as if their life expectancy will be greater than 10 years. So even if they're over the age of 70, if they're in great health, a lot of our patients will still be screened. And then also in terms of screening over age 70, bone density is very important. And we usually continue those every 2 years as long as the patient is in good health. And as far as endometrial cancer, it's not recommended that we screen for endometrial cancer. And again, that's the white part of the light bulb. Unfortunately, we have some patients come in and, they have endometrial cancer and they'll say to me, well, I got my pap smears regularly. I don't understand why this wasn't picked up. And I explained to them they're only testing the silver part of the light bulb with the pap smears. We're not testing the white part. So we don't routinely do screening for that. Your screening test is abnormal bleeding, whether it's light red, pink, rust color, brown, anywhere in the spectrum of blood or red, you need to be seen by a provider if you're, any age and having abnormal uterine bleeding. The only times we do screen in those patients are if they have a genetic abnormality. The same goes for ovarian cancer. There's no effective screening tests for ovarian cancer. And as Dr. Deegan mentioned, colonoscopy. Most people say stop at age 75, and continuation depends on risk factors and health screening. So it's important for women, regardless of age, to be aware of the changes in their body, as Dr. Deegan has also mentioned, and report unusual symptoms or concerns to their healthcare provider. Getting regular checkups is important. If not annually, allow older women to discuss any health concerns and stay informed about their overall health. So individual health risk factors, looking at life expectancy and quality of life, and report your symptoms or concerns.
Okay. Sarah, can I jump on to this point? Because I think it's really important. Dr. Wilson-Smith did a great job of going through those guidelines, but especially for mammogram, I think, in my opinion, those guidelines cut off way too early. People are living longer, they're taking good care of themselves. And so I always recommend that if a woman is fit enough to undergo the treatment for the breast cancer, and yes, for a lot of women, that's a surgery, and that's not to be taken lightly, but even if surgery is not an option, there are still usually ways to control the cancer. So I recommend that you consider that.
Thank you. Okay, and I know that you had talked about health history, and I think this next question kind of ties into it. Dr. Deegan, this person is wondering, if both parents had cancer before they died, is it definite that I will get it?
Yeah, understandable concern. It's always scary when you've had loved ones go through it. And of course, you think about your own risks, but not necessarily. There are certain cancers that are more likely to be inherited than others. So for example, we know that lung cancer is most often a smoking-related cancer. So it's unlikely to be something that would be inherited from mom and dad. There are other cancers such as breast cancer, pancreatic cancer, prostate cancer, and those can be inherited, although overall only about 10% of cancers are inherited. So that means the other 90% are not. They're probably due to some combination of patient and environmental factors.
Okay, thank you. All right. We will turn back to you, Dr. Wilson-Smith, and talk a little bit about the gut microbiome. I know that's kind of a trending topic, so interested to dive in here. So is there a link between the gut microbiome and cancer?
So this is a very new area. And yes, there is emerging evidence suggesting that there's a link between the gut microbiome and cancer. And I think we first have to define what is the gut microbiome. This is a community of microorganisms that live in our gut. So we have this little city that lives in our gut, composed of bacteria, viruses, fungi, and other microbes. And some of the ways that the gut microbiome have been linked to cancer can be good and bad, depending on whether you have more good or bad happening in your gut. So some gut microbiome can cause chronic inflammation. So a great example would be H. pylori in relationship to our stomach and how it promotes inflammation and can cause DNA damage and cancer. Some gut microbiome can cause production of carcinogens, which are agents that cause cancer. You can have metabolism of dietary compounds that can get rid of dietary components that cause cancer to activate them. So that would be a good thing. It can also modulate our immune system, and they play a role in training or changing our immune system that can influence cancer development or make it harder for cancer to actually develop. It can also have an effect on cancer therapies that we take. For example, immunotherapy like checkpoint inhibitors, some bacteria seem to enhance the therapy's effectiveness, and others make it worse. It also, as I mentioned, can be protective against cancer, and it can impact our hormone levels, such as estrogen, which a lot of our cancers are estrogen driven, like breast cancer or endometrial cancer. So in summary, it's a challenging to study because the microbiome complexity, as well as the individual variability and interactions with diet and environmental factors and genetics. So all of us are different. We all eat different things. We all have different genetics. And so it's really difficult to study the gut microbiome. In the future, as our understanding grows, it's hoped that insights into the gut microbiome can be harnessed and to develop new preventative and therapeutic strategies against cancer. But until then, maintaining a healthy gut through a balanced diet, regular exercise, and avoiding unnecessary antibiotic use is generally recommended for overall health. Right now, here at Jefferson, we have a breast clinical trial open right now, I believe, Dr. Deegan, where we're looking at diet and how it impacts with regards to intermittent fasting. So, these are all, diet is an area that we're starting to really delve into and look at and see how it impacts how we do in terms of cancer care.
Wow. Yeah, that's fascinating. It'll be interesting to see the research that comes out of that. So thank you. Okay. Dr. Deegan, we will turn back to you for this next question. What symptoms are commonly overlooked or maybe brushed off?
Sure. So I first want to reassure everyone that most things are not cancer, but we all know our bodies best. And again, that's why it's important to just kind of take stock and be aware of what your body's doing. And if something doesn't seem right to you, it's very important to talk to your doctor and don't stop until you're heard. But concerning symptoms would be things like pain that doesn't go away, a persistent cough, lumps or bumps that you can't explain, unexplained weight loss. Those are things that I generally think of as concerning symptoms that I would want to pursue further. I see a lot of breast cancer, as I mentioned. So one of the things that I hear occasionally is a woman who's breastfeeding who notices something and is then kind of brushed off and just told, oh, it's, related to breastfeeding. So that's just an example where I think if something's not right, talk to your doctor. I would 100% rather reassure someone that I meet in the office that it's nothing than find out that they have a cancer that could have been detected earlier.
Absolutely. Yeah. Thank you for walking through those symptoms and just things to monitor and listen to our body, as you said. Okay. Dr. Wilson-Smith, question for you. What are the risk factors in minority women over 50 for cervical and or uterine factors, and how often should there be screenings?
Okay. So the screenings would be exactly the same as any ethnic group. And the risk factors, believe it or not, is the same as well. It's just the prevalence for certain risk factors may be higher in certain ethnic groups versus others. Also higher in certain class groups financially. So it's a very complicated question because your risk factors aren't just based off of, you know, being minority. There could be so many different other things involved. But in terms of risk factors for cervical cancer, it would be HPV. That's the #1 risk factor, human papillomavirus, which is a sexually transmitted virus. 80% of women by the time we turn 50 have been exposed to this virus. So this is a very common virus. But I want to make sure I say that just the majority of women who have cervical cancer have HPV, but the reverse is not true. The majority of women who have HPV never develop cancer. So I try to make that really clear to our patients when we see them, because you know you hear so much about cervical cancer and HPV. It's really scary to get that diagnosis. But another one would be HIV, smoking, immunosuppression, chlamydia infection, diets low in fruit and vegetables, long-term use of oral contraceptives, multiple full-term pregnancies, multiple sexual partners, social economic status. Our screening right now for cervical cancer, as we mentioned, we started 21 to 29, getting a pap smear every 3 years with reflex HPV. And basically what that means is you do the pap smear. If the pap smear comes back low grade, then we will reflex, or then we will reflex for HPV and see if HPV is present. The reason we changed the age from 18 to 21 is because women 18 to 21, that's the time when most women are becoming sexually active, and you're going to see a high prevalence of HPV, and it's unheard of to find cervical cancer in those patients. It takes about a good 15 years to go from HPV infection to invasive cancer. So, you know, for us to test all of these women, which have very robust immune systems and they're going to clear the virus, doesn't make sense. We're doing all these biopsies and pap smears and colposcopies and leaps on them, and then they have problems down the line when they're trying to get pregnant. So we push the age back to 21. And again, as I mentioned, some people are trying to push it to 25. At age 30 to 65, it's pap smears every 3 years with HPV, every 5 years. So now that changes. It's every 3 years if it's pap alone, but it's every 5 years if you're doing pap and HPV. And one of the things I get asked a lot is, why are the insurance companies saying that we can only get pap smears every 5 years? You know, are they trying to save money? What's happening there? Well, I always like to think of it like this. If you took regular Tylenol, you would take it a certain amount of time. But if you took extra strength, you have a longer time period where you need to take it because it lasts longer. So with pap smears, we were only testing the symptoms of HPV. Now with HPV, we're testing the cause of these abnormal pap smears. So the combination of those two things makes the test stronger. So the chance, if you have a negative pap smear and a negative HPV, the chances of you developing cancer in the next 5 years is very, very slim. So we're trying to do less to people. And that's the reason why, because it's not necessary, not because it's necessarily just a financial cost. And then, as I mentioned earlier, over 65, you know, depending on your particular scenario, we can consider stopping as well. HPV vaccination has also played a role with this as well. And then with regards to uterine cancer, risk factors are increasing age, obesity, hormone replacement therapy without progesterone, tamoxifen, high fat diets, diabetes, PCOS, endometrial hyperplasia, and Lynch syndrome. And again, we have no screening test for this. And in terms of minority women, especially specifically African-American women, they tend to have higher grade tumors in the endometrium, and they tend to do worse. And just recently, there was a clinical trial that came out that showed that our guidelines were saying that if you had an ultrasound for bleeding and your stripe was very thin, that you didn't need to do a biopsy. But we realize we're missing a lot of African-American women because they're getting these high-grade tumors that have thin linings. And so, you know, that's a healthcare disparity. And, you know, they're saying that we really need to be paying attention to that and still maybe sampling those women in that scenario. So with regards to minority populations, the challenges are we have higher rates of obesity, healthcare access, cultural beliefs and habits. I'm sure many of you are aware of the data looking at hair relaxers and the link to uterine cancer, the potential link to uterine cancer and how, you know, and breast cancer and how this needs to be further studied. There's biological factors with minorities. They're more likely to have aggressive tumors. The quality of care and receiving guideline concurrent care. There have been multiple studies that have shown that if you are a minority woman, sometimes it's more challenging to get guideline concurrent care. Underlying medical problems like diabetes and hypertension. And then to me, very importantly, is enrollment in clinical trials. You know, I really encourage minority women to enroll in well-designed clinical trials so that we're represented in the data, so that we know how to treat minority women as well. Thank you.
Thank you so much. Some really critical information there. So thanks so much for walking through that. We really appreciate it. Okay, we will go to the next question here. Dr. Deegan, I know we previously talked a little bit about lifestyle factors, so just want to dive into that a bit more. So can you talk about maybe nutrition and maintaining an active lifestyle as it pertains to reducing cancer risks?
Yeah, we know that maintaining a healthy diet and a healthy, active lifestyle is good for a lot of things. So your brain, your heart, your immune system, and it also may reduce the risk of cancer, as you said. And so there is research that has linked processed foods, such as things like bacon and packaged snacks and sugary cereal, and linked those things to an increased risk of cancer. There's also some linkage between red meat and alcohol if those are consumed in excess. And we're not entirely sure what exactly the link is, whether or not it's carcinogens in the food themselves, or maybe just a link to obesity that can develop with consumption of those sort of products. But it's probably a combination of many factors. And so, you know, I always counsel my patients that they should maintain a heart healthy diet, a Mediterranean diet if possible. And that goes for people going through treatment as well. You know, it's certainly not the time to diet, but you want to maintain a good diet, maintain activity as much as you can.
Okay, thank you. All right, we will go to the next question here, Dr. Wilson-Smith, coming back to you. When do ovarian cysts become a concern?
Well, most ovarian cysts are completely benign and will go away without treatment. I have patients come in and they'll say, oh my God, I had a cyst. And I tell them you have a cyst every month if you're premenopausal. But I don't think that most people realize that, you know, every month when you ovulate, you have a cyst that forms on your ovary. Your body's constantly trying to get pregnant. And then eventually by the end of the cycle, if you don't get pregnant, that cyst goes away and it starts all over again. You start to make another cyst on the ovary, it gets to be about 2 to 3 centimeters, it ruptures, and then we start all over again. It's the stubborn ones that don't want to go away. It's the ones that start growing thick septations and that are persistent, that have abnormal blood flow. They get to be like 5 and 10 centimeters. They may cause like pain and bloating and discomfort. You know, the other ones that you have to worry about if you're postmenopausal and you have a cyst, your ovaries should be quiet. They should not be making cysts. So we do get a little more concerned about those, and we do, you know, watch them closely and sometimes remove them. If you had a personal history of cancer, whether it be breast cancer or you know, any other type of cancer, the ovaries tend to catch everything. I always say you can have breast cancer and you can have Mets to the ovary. You can have pancreatic cancer and have Mets to the ovary. I've taken women to the OR to remove a cyst, and it's from their thyroid. So, you know, the ovaries can catch a lot of different things. So you do want to have it evaluated, especially if it's persistent. And also if you're having torsion, which is where the ovary twists on itself because it's too heavy to be supported by the uterus, sometimes it can twist on itself and cause an incredible amount of pain. Sometimes when you see us, we might order tumor markers depending on your scenario. And those are proteins that can be picked up in the blood. They're not for screening, but they're to help us with the overall picture to determine how high risk you are. So in summary, management would be based on the individual's age. It would be based on the size of the cyst, the appearance of the cyst, whether there are symptoms, whether the patient's postmenopausal or premenopausal. Treatment can consist of observation or follow-up ultrasound. Sometimes we'll have you come back and we'll say, when you get, especially if you're premenopausal, we'll say, when you get your period, get the ultrasound done at the tail end of the period. We don't want to wait till mid-cycle, day 14, where we're definitely going to see a cyst. That's going to be there, that's supposed to be there. Sometimes we'll manage with hormonal medications or surgery or potential management options depending on the specific circumstances. We are much more cautious these days about just removing the ovary because of the possible long-term health consequences that we discussed earlier. We are also more cautious about removing it because it's not always necessary. We recognize that the postmenopausal ovary continues to have some function even after menopause, including unlimited production of hormones, particularly testosterone. So we know that they can work all the way to the 8th decade of life. So it's important that you have a very careful discussion with your provider before just taking out your ovaries, because they're so, so very important.
Okay. Thank you. And to echo, I did not know I have a cyst every month. So thank you. Learning something new every day. So, okay. Dr. Deegan, we will turn to you. Does breast cancer risk increase with age?
It does. So breast cancer is a disease that's associated with aging. The median age at diagnosis is about 62 years old. But the risk varies throughout a lifetime. So the risk of having breast cancer in the next 10 years for a 30-year-old woman is about 1 in 200. The risk for a 70-year-old woman is about 1 in 24. Overall, the lifetime risk of breast cancer is about 1 in 8. So it's pretty common, unfortunately. And there are various risk factors that make that number higher or lower, make the risk higher or lower.
Okay, thank you. All right, we will turn to our last question here and then turn to some live questions from the audience, and we see those coming through. So thank you all for being so engaged in submitting those questions. But for our last question here, before we get to our live questions, Dr. Wilson-Smith, are there long-term side effects to radiation and chemo treatments for breast cancer and cervical cancers?
Great question. This is radiation and chemotherapy are difficult because they're effective at treating cancer. However, you can still develop symptoms from the normal cells being damaged months to years after the treatment has ended. So, for example, for breast radiation, some of the side effects can include cardiac problems, lymphedema, lung problems, shortness of breath, coughing, changes in the breast appearance, size, shape, and texture. You can also develop secondary cancers such as sarcomas or lung cancers from radiation exposure as well. With regards to chemotherapy and breast cancer risk, you can also develop cardiac issues, cognitive changes, menopausal symptoms. You can have problems with your bone health and secondary cancers like leukemia. For cervical cancer, because now we're radiating a totally different part of the body. So, down in the pelvic area, you can have bowel issues, including diarrhea, constipation, bladder problems like inflammation, pain, frequent urination. You can have vaginal changes and vaginal stenosis where the vagina gets closed off. And a lot of times we try to mitigate this by afterwards using vaginal dilators twice a week or maintaining an active sexual life as well. We'll keep it open as well. Vaginal dryness, sexual dysfunction. Radiation can cause lymphedema, which is swelling in your extremities and your legs. Can also affect your bone health as well, and increased risk of fracture. You can also develop secondary cancers in the pelvis as well. In terms of chemotherapy for cervical cancer, you can develop neuropathy, which is numbness and tingling in your fingers or toes, and sometimes in your legs. You can have menopausal symptoms, kidney damage, and then again, a secondary cancer later in life. But it's really important to note that although these are potential long and short-term side effects, not everyone is going to experience them, and their severity can vary from person to person. It is also very based on the type of radiation and chemo you get, the dose, the treatment duration, the area being treated, and the individual patient's characteristics. We also have various options, as I mentioned, that can help mitigate some of these problems, like physical therapy. We send a lot of our patients to rehab during treatment in order to mitigate some of these things. I mentioned the vaginal dilators. So there's a lot of things that we can do to help with these symptoms as well. And we usually address these during survivorship. We have our patients meet with our survivorship nurse practitioners who will help them with these things as well.
Okay, well, thank you. And with that, I think we'll go ahead and dive into our live questions from the audience. So to start off our live questions, I will turn to you, Dr. Deegan. This person is wondering, how often should a 45-year-old woman get a mammogram? Is yearly necessary, or is every other year okay if you don't have a family history or risk factors?
Yeah, we recommend yearly mammograms for all women, really. And that's because even without a family history, a breast cancer can develop, and it can develop, within a year. It can develop between mammograms. So it is good to keep up that surveillance. I think the other thing that's important is that you always want to have mammograms to compare. I mean, in general, that's true for all sort of imaging that you get. The more studies you have to compare, the easier it is to figure out if something new is going on. And young women tend to have very dense breasts, which can make mammogram challenging. So sometimes we recommend adding an ultrasound, and some women qualify for an MRI for that reason. But again, because the breasts are so dense, some very small areas can be obscured. So you really want to have consistency year to year so you can be aware of what sort of the normal is and then look for changes carefully.
Okay, that's good to keep in mind with the consistency there. So thank you. Okay, Dr. Wilson-Smith, can or should women get a bone density screening in their mid-40s? This person is wondering.
We have many women that qualify for bone density screenings. For example, if someone's on certain types of hormone therapy, and they've been on it for a very long period of time, like I have some patients on Lupron, Depo-Provera, and you're concerned about their bone density, we will get it in those scenarios. Or if someone had premature menopause for a long period of time and you're concerned about their bone density, we can also order it in those scenarios as well.
Okay. All right. Another question for you here, Dr. Wilson-Smith. Is there a screening for ovarian cancer?
No, we have failed so many times at trying to get a screening test for ovarian cancer. There have been multiple attempts. There have been sophisticated algorithms that have been created using ultrasound and CA-125. The problem is, I am sure we've all gotten the email, ask your doctor for CA-125, this could have saved your life type of email. And, the truth about CA-125 is half of ovarian cancers, especially stage 1 ovarian cancers, don't even have an elevated CA-125. You can have a belly full of tumor and your CA-125 can be normal. You can have an elevated CA-125 and be on your period. You can be pregnant, have an elevated CA-125. You can have heart disease. You can have liver disease. You can have, all kinds of things, your fibroids, endometriosis, and have elevated CA-125 level. So it's not a very specific, sensitive test to screen with. And so the data has shown that if you take, let's say 100 women in one group, 1,000 women in one group, 1,000 women in the other, and one group you use usual care and the other group you screen with CA-125 and ultrasound, you may find one ovarian cancer, but how many women, it's an unacceptable amount of women that had to suffer as a result of the screening test, meaning they went to the operating room for something that was small or for an elevated CA-125, and then they had a complication from our intervention. And then in those scenarios, it's not worth, the screening test. So we have failed miserably, and they're still working very hard to try to develop an adequate screening test for ovarian cancer.
Okay. Thank you for that information there. All right, Dr. Deegan, a question for you. And I know that, we had talked about this previously about the effects of radiation, but this person is wondering, is it true that getting too many mammograms is not good for you? Are there any negative aspects of a mammogram? Do you mind just touching on that a little bit more?
Sure, yeah. I mean, that is true that a high amount of radiation can cause cancers. Certainly, the doses that we use for treatment are very, very high when you compare that to what's in a lot of the imaging studies that we do. But the amount of radiation in a mammogram is extremely low. There have been no studies that I'm aware of that have proven any link between mammograms and then getting cancer. Again, I think everything is a risk benefit calculation. So the benefit of getting yearly mam far, far outweighs the risk of any small amount of radiation exposure.
Okay, thank you. All right, another question for you, Dr. Deegan. This person is wondering if someone has a preventative bilateral mastectomy because of genetic risk factors, is there still a chance of developing breast cancer?
Yeah, so I think the gene we know the most about, or think the most about in terms of breast cancer and inherited breast cancer risk, is the BRCA genes. And so, as this person mentioned, many women with BRCA mutation are recommended for risk-reducing mastectomy. And the risk of breast cancer in women that have that mutation is anywhere from 30 to 60% in their lifetime. So it's extremely high. And that surgery reduces that dramatically. I don't know the exact number, but I would imagine that it's close to the general population risk, if not lower.
Okay, thank you. All right, Dr. Wilson-Smith, at what age does a woman no longer need to go for GYN checks? At what age can a woman stop getting mammograms? Again, I know we touched on this a little bit, but if you could reiterate, that would be great.
I'll leave the mammogram part to Dr. Deegan, but I think we said as long as the patient is in good health and life expectancy is at least more than 10 years, I would say the same thing for the GYN exam as well. I personally still recommend, as long as you're in good health, still go for your GYN exam. And I know someone else had asked, if you're still going for your annuals and you're not getting, no longer getting a pap smear done, do you still need to go? I just wanted to tack that on there as well. When we're in the GYN exam, we're looking at your abdomen. We do a breast exam. We are looking at the outside of the vagina, which we call the vulva. We are looking around the rectum. We are looking in the vaginal vault as well, and making sure that there's nothing abnormal that needs to have a biopsy or attention to. We're asking you questions about your health that maybe you haven't thought of. I have a lot of women who say they were bleeding for 3 years, but they just thought their period came back because they didn't know at 70 that your period shouldn't come back. So, or that it was just rust color. They didn't know. So I think having that touch point once a year is important.
Mm-hmm. Absolutely. Okay, thank you. All right, Dr. Deegan, should I be concerned if I have a high platelet count, and is that a sign of cancer?
Yeah, so I'll start with kind of the basics about blood. So the body makes 3 types of blood cells. You make white blood cells, red blood cells, and platelets are the small fragments of cells in our blood that help us clot when we bleed. So you cut yourself, shaving your legs, you bleed a little bit, but eventually you clot, and platelets are involved in that process. So there are several reasons to have elevated platelet count. And the common things are common. So platelets can often go up and down in reaction to things that are inflammatory. So things like infection, other inflammatory conditions. Another common thing that I see is women that are iron deficient. For example, women that have very heavy periods will often become deficient in iron, and that can drive up the platelets. There are rare blood disorders that fall under the spectrum of blood cancers, where the platelets are very elevated. But usually when I see someone, I take a good history. I do some sort of preliminary testing first. I rule out iron deficiency. And then there's testing to make sure that it's not one of the blood disorders that I mentioned.
Okay, thank you. All right. Dr. Wilson-Smith, can you please repeat the mentioned risks related to tamoxifen, if I pronounce that correctly? But I know you had mentioned that earlier, and this person would like you to expand upon that.
So women who take tamoxifen are at slight increased risk for endometrial cancer. They are also at increased risk for having polyps in the uterus as well. So these patients, your screening test again is bleeding. So if you have abnormal bleeding, then usually you would come and see your GYN, and then we would need to sample the lining of the uterus just to make sure. I always say that postmenopausal bleeding is cancer until proven otherwise. Even though it's not most of the time cancer, we have to rule it out, is basically what that means. So those are the things that tamoxifen can cause, because it acts opposite in the uterus than it does on the breast. At the breast, it's decreasing estrogen. In the uterus, it's increasing.
Okay, thank you. All right, Dr. Deegan, this person is wondering, when cancer is detected early and removed, what can cause it to come back years later?
Yeah, I assume the question is about breast cancer. So as I mentioned, with mammograms, we're finding a lot of breast cancers early, and taking them out with minimal, and then requiring minimal treatment. There are really three subtypes of breast cancer. So the most common is what's called estrogen progesterone positive breast cancer. That's about 60 to 70% of breast cancer cases. There's a subtype called HER2 positive breast cancer. That's about 15 to 20%. And then if the tumor doesn't express either of those three markers, the estrogen receptor, the progesterone receptor, and the HER2 receptor, that is called triple negative breast cancer. And we treat them each pretty differently, and they each have sort of their own prognosis. So, for example, triple negative breast cancers are the most aggressive subtype. They have the worst prognosis. It's the area that I feel we need to make the most strides to do better for our patients. But those cancers have a higher risk of recurrence even after they've been removed, and even after whatever treatment otherwise has been necessary. And that includes chemotherapy, sometimes immunotherapy, radiation. And that tends to happen within the first 2 years. That's the highest risk of recurrence. HER2 positive breast cancers are sort of the next most aggressive. They're less aggressive than triple negative, but they're still considered aggressive. However, our treatments have really gotten a lot better, so the prognosis has improved greatly. Those also tend to occur within the first 2 years. Estrogen receptor and progesterone receptor positive breast cancers are a little bit different in that they can actually have recurrence that takes place many, many years later. And so, when I meet a new patient with breast cancer, I want to figure out which subtype they are and what's the appropriate treatment. And we talk about things that we can do to reduce the risk of recurrence.
Okay, thank you. All right. Another question for you here, Dr. Deegan, or Dr. Wilson-Smith, if you want to jump in here too. I know you both had mentioned this person is interested in learning a little bit more about the success of intermittent fasting that you had mentioned for the treatment of cancer. Can you expand on that?
I'll let you take that one, Dr. Wilson-Smith.
Right. So there's some data that shows that intermittent fasting, some preliminary data may help the cancer therapy to work better. And the basic premise that they're going on is that cancer cells need a lot of energy. They're very rapidly growing cells. And that's what makes it cancer. They don't know, they're cells that don't know how to die. All of our cells go through programmed cell death. They live their life and they die. And then we make new cells. These cells are, they just keep going. They're like the Energizer Buddy. So our normal cells, we have protective things in those cells that allow us to be able to go periods of time without eating, without cell death of those normal cells. Whereas, cancer cells may need a lot more energy. So the thought process is, by restricting eating for a certain amount of time, and then giving cancer therapy, does that help the treatment? So the current breast cancer trial, I can't remember the name of it, but there's a current breast cancer trial that we're doing right now at Jefferson, where they're actually looking into that. And there's a lot of data on intermittent fasting right now, and different schedules that can be used, whether you use 6-8, if you do, some people do what they call an OMAD diet, 1 meal a day. But I would say that if it's something that you're interested in, make sure you touch bases with a nutritionist. Make sure that also you are in contact with your primary provider so that you can have baseline labs, and so that that you're getting the proper amount of nutrition, especially if it's drastically changing your diet. But there's some data now and clinical trials ongoing, and it's pretty exciting.
Yeah, really interesting to hear that research. So thank you. And thank you for the question. Okay. Dr. Deegan, for women who have dense breasts, can an ultrasound be used for annual screening instead of a mammogram, and or are both needed?
Yeah, right now the guidelines are for mammogram. As I said, we often combine ultrasound with mammogram. It's sort of the yin and the yang. You get a little bit of something from each type of modality. So I would not suggest that you substitute ultrasound. I think mammogram plus or minus ultrasound, depending on the density of your breast. What will happen, and I know this from having had my first mammogram this year, is that they will do the mammogram and then they may suggest that you get additional imaging done. Either, of course, because if there's something concerning, they will let you know about that. But again, if they feel the density of the breast is such that an ultrasound may help them, then they will suggest that as in addition.
Okay, thank you. All right. Dr. Wilson-Smith, we'll turn back to you. Since there is no screening for ovarian cancer, what symptoms can we be alert for?
They're very subtle, which is why it's so difficult to catch ovarian cancer. Most ovarian cancers are diagnosed at stage 3 and 4 because, and I see this all the time where patients have seen their primary care, then a GI doctor, then, you know, back to the primary care. And because some of the symptoms can mimic bowel symptoms. So you get full very easy. You have bloating, your abdomen's distended, you're having problems with urination. It could be, you could have problems with constipation as well. So they're very subtle. Abdominal distension, you can have fluid in your abdomen all of a sudden, or you can have reflux where you eat something and then now you have this intense burning. So if you're having these symptoms persistently and they're not going away, then, you know, you should go and see your GYN because sometimes that could be the reason as well. They've done a few studies looking at women who have stage 3 and 4 ovarian cancer, and almost all of them can give like a certain time period, 6 months, a year, where these symptoms were going on. So there's a lot of research looking at, you know, maybe screening tests that might be more sensitive to picking up ovarian cancer earlier as well.
Okay, thank you. Okay, we will continue. Thank you so much, everyone, for submitting these live questions. They've been great, and I know that we're receiving a few more, so we will go ahead and hang on here. So for this next question, let me see. Dr. Wilson-Smith, we'll turn back to you. During menopause, if you are experiencing low energy, are there ways to regain it back?
Yes, I would say one, and we've touched on this a little bit already. Diet and nutrition, very important. Looking at what we're eating. As Dr. Deegan mentioned, try to take out of your diet a lot of the processed foods that we're eating. Also, exercise. Exercise is so important. There's a lot of endorphins and things that we release when we're exercising regularly on a regular basis and we're active that will help with our energy level. Limit alcohol consumption, as Dr. Deegan mentioned as well. Getting proper rest, avoiding tobacco, staying hydrated. These are all things that can, you know, that you can do to try to increase your activity level or your energy level, but also seeing your provider and maybe getting some blood tests done just to make sure that there's not something else going on that might be causing you to have this this low energy. And eating a diet full of fruits and vegetables.
Okay, thank you. All right. Dr. Deegan, what are your thoughts on thermography for breast screenings? Is this an option?
Yeah, so I'm not familiar with that as part of any guidelines. So I'm a little bit of a purist and I like to follow guidelines because most of the time they come from very, very smart people that are experts in their field and they're based on a lot of data and, you know, things that we learn as we go. And I'm not aware that they're part of any guidelines. So again, I wouldn't substitute that for mammogram at this point.
Okay. Thank you. All right, another question for you here. Is there a connection between too much calcium and breast cancer?
So I think there is not a connection between high calcium and breast cancer per se, but occasionally a high calcium can be a sign of cancer. I'll back up and say what I said before, which is that most things are not cancer. But high calcium should be investigated. By far, a more common cause would be things like problems with the parathyroid gland or with the kidneys. But that can sometimes be a presenting symptom. Usually there are other things to go along to clue you in, but it should be investigated. It should be repeated. There's a nice sort of algorithm that we follow. If you have a high cancer, check this. If that, then this, to kind of go through the workup and figure out why the calcium's elevated, and then it can inform what you do about it.
Okay, thank you. All right, Dr. Wilson-Smith, turning back to you. Does early menopause increase chances for breast or ovarian cancer?
I will speak specifically about the ovarian cancer. If you think about the ovaries, from the time that you start ovulating to the time that you go through menopause, every month when you're ovulating, your ovaries are busy and they're constantly working. And when your ovaries are busy and constantly working, that's when they're at the greatest risk of having a malignancy or a problem happen. So for us, it's early getting your period and late menopause. It's opposite. And so I always think about this as well. Women who breastfeed, they have a lower chance of ovarian cancer because they go periods of time where they're not ovulating because they're breastfeeding. Same thing if you are on birth control or oral contraception. Your ovary is put at rest for a certain period of time. So women who've been on birth control for over 5 years reduce their risk of ovarian cancer significantly. So if you go through menopause early, then your ovaries are quiet as well. So that's how I always think about, risks when a person has multiple children. Let's say that she has 10 children. That means for almost 9 years that she was pregnant, her ovaries were quiet. So she also has a lower risk of ovarian cancer. But I'll leave it to Dr. Deegan for that one, for the breast cancer part.
Sure. So there are lots of health kind of risks associated with early menopause, some of which we talked about: changes to bone density, cardiac problems, cognitive things. Increased risk of breast cancer isn't one that I tend to think of. In fact, for some of our young breast cancer patients, actually inducing menopause is part of the treatment. For those patients that have estrogen receptor and progesterone receptor positive breast cancer, depending on the stage of the cancer, that is sometimes something that we do. So hormone manipulation in breast cancer is oftentimes a part of the treatment. So I don't think it would increase the risk significantly.
Okay. All right. And we have about one question left here before we will go ahead and wrap it up. So for our last question of the night, Dr. Deegan, is it true that breastfeeding reduces risk for cancer?
Yeah, I think as Dr. Wilson-Smith alluded to, there are many benefits to it, both for mom and baby. So yeah, in general, I think we feel that it does decrease the risk of certain cancers.
Okay, great. Well, thank you again, everyone, for these wonderful questions. I know I learned a ton and really appreciate your thoughtful and insightful answers. So yes, thank you again, both Dr. Deegan and Dr. Wilson-Smith, for taking the time this evening. We really appreciate it. A lot of great information was shared about women's wellness. And thank you all for attending and submitting such great questions. We will be posting an event survey, so you can let us know your thoughts. Was this helpful? Are there any other specialties you would like to hear from? Your feedback will bring more virtual events like this to you, the patients. And if you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. We have more wellness webinars coming up soon. If any topic is of interest to you, be sure to sign up. A recording of this event will also be sent to you so you can rewatch at your convenience. And if you would like to view other Wellness Webinar Series events, please visit our Jefferson Health YouTube channel at youtube.com/Jefferson Hospital. We have everything from back and neck pain to robotic surgery to planning for pregnancy and much more. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening and good night.